The topic today will be Pediatric Anesthesia Part 1. This will be the first section of Pediatric Anesthesia. My name is Brian Blasio. I have nothing to disclose. Pediatric anesthesia is a unique field of anesthesiology that requires a broad understanding of the anatomic and physiological changes with age. It is also important to appreciate the developmental psychology of the patient, as well as the role of the parent in supporting their child at the different stages of development, from the neonate on to the adolescents and teens, as you help them navigate through their surgical or diagnostic experience that requires anesthesia. Finally, pediatric anesthesia requires use of similar tools that are used in adult anesthesiology. However, the smaller size of the patients can be a limiting factor in some of the tools and their usefulness as well as applicability. Start off with the pediatric airway. There are some major differences from adults and some unique characteristics that makes approaching the pediatric airway different in some ways. Number one, children have a large occiput, at least in the infants, compared to the adult. Many times this can force the head into flexion, and this potentially causes upper airway obstruction and can make it difficult for optimal positioning during the direct laryngoscopy. Children also have a more cephalad positioned larynx, and that's more characteristically noted on the direct laryngoscopy. This makes it more conducive to actually using a straight laryngoscope blade as opposed to the curved blades in adults. Number three, children have larger tonsils and adenoids. This can lead to upper airway obstruction during the inhalation induction or on waking up in the recovery room. It also can make for difficulty in visualizing the larynx during the direct laryngoscopy. Finally, pediatric patients often have an omega-shaped epiglottis, and this can make manipulation of the epiglottis itself more difficult. Again, this makes the straight blade laryngoscope makes the provider more able to control the epiglottis itself as opposed to a curved laryngoscope blade. Overall, the smaller size of the pediatric airway requires more delicate movements during the direct laryngoscopy. Primary teeth erupt during the first year of life, and somewhere between 6 and 12 years is when the secondary teeth begin to erupt and the primary teeth are shed. The airway exam should always note whether there are loose teeth, regardless of age. However, it's very important during the ages of 6 and 12 that there isn't a particularly loose tooth that could be dislodged during the direct laryngoscopy. Children oftentimes have recently had a cough, fever, or cold, and many times this makes them more prone to laryngospasm. Laryngospasm is a feared complication that can occur any time during the anesthetic, during induction, as well as on emergence after the airway is no longer protected. Laryngospasm itself is a protective mechanism. It occurs by forced adduction of the glottic and supraglottic laryngeal muscles. This results in airway obstruction. It could be anywhere from complete obstruction to less severe, and they're able to move some air through the larynx itself. Laryngospasm is mainly triggered by stimulation of the glottic structures during stage 2 of anesthesia, but as mentioned, it can occur at any time. The major risk factors, as I mentioned before, is URI, either an ongoing upper respiratory tract infection or a recent one. Other risk factors include secondhand smoke exposure. Treatment for laryngospasm includes a jaw thrust and positive pressure ventilation with a mask. However, if this is unable to relieve the laryngospasm and you note decreasing SATs or inability to open the airway or move air, propofol at 1 milligram to 2 milligrams per kilo is often recommended. In addition, if propofol is unsuccessful, succinylcholine can also be given via the IV route, or if no IV is obtained at this point, an IM injection of succinylcholine can also be administered to break laryngospasm. Noisy breathing is an ominous sign, as it is concerning for impending airway obstruction or respiratory failure. Stridor is a barking, croupy cough. If it's associated with substernal retraction, nasal, and rib cage flaring, then there is concern for impending respiratory failure. Most commonly, it's associated with subglottic edema from endotracheal tube irritation. Management largely depends on the cause, which depends again on the surgical procedure, the clinical exam, as well as the saturation of the child. Typically, stridor resolves over time. However, if saturations are not improving and time is not leading to improvement of the symptoms, dexamethasone can also be given, as well as a nebulized solution of racemic epinephrine. When stridor is associated with expiration, it's typically lesions that are distal to the epiglottis. An inspiratory stridor usually involves the upper airway, whereas a biphasic stridor can be due to a subglottic obstruction itself. These are some additional causes of stridor, although in the pediatric anesthesia world, the subglottic croup or subglottic post-intubation stridor is the most common from irritation of the endotracheal tube. There are other unique pediatric airway concerns that have to do with certain disease states. One important one in pediatrics is the congenital diaphragmatic hernia. This occurs when there's extrusion of the intra-abdominal organs into the thoracic cavity from a hernia in the actual diaphragm. What's noted is a scaphoid abdomen and an expanded thorax, and this may be obvious on the exam depending on how severe the hernia is. Also noted on exam will be breath sounds are absent on the affected side. The extrusion of the intra-abdominal organs causes or prevents normal prenatal lung growth and development, and this results in lung hypoplasia and pulmonary hypertension, which could possibly be incompatible with life. Most commonly, the diaphragmatic hernia occurs on the left in the foramen of Böchtelecke. These children should be managed by avoiding positive pressure ventilation by masks, as this could potentially insufflate the stomach and cause almost a pneumothorax type phenomenon in the thorax itself, decreasing the ability to ventilate the child. Ventilatory management of these children is a balance between avoiding barotrauma of the hypodeveloped lung on the unaffected side, but on the other hand, avoiding factors that might increase PVR due to the increased pulmonary hypertension that these children often develop. Small tidal volume is typically used to avoid volutrauma. PEEP is often encouraged, and permissive hypercapnia without hyperoxia is also often used to manage these children's airways and respiratory status. Unexplained intraoperative decrease in lung compliance and hypoxemia or hypotension can be suggestive of a contralateral pneumothorax during the surgery, and this is typically due to overinflation of the unaffected lung. And this needs to be immediately evacuated with either a needle thoracotomy or by a chest tube placement. Another unique pediatric airway concern is the tracheoesophageal fistula, or TEF. These occur in 1 to 3,000 births and can exist in 5 different forms as shown in the slide. The most common type is type C, which is on the left. And this consists of esophageal atresia with distal TEF. Most commonly, these are diagnosed after birth when there's inability to pass an NG tube into the stomach. Infants with TEF will have a gastric air bubble on radiograph. These children often have the associated Vactorol or Vactor complex, and they have additional congenital abnormalities that may or may not be present. An important one to note is the possibility of congenital heart disease in these patients. Preoperatively, all of these children should receive an echocardiogram to rule out any intracardiac or congenital heart disease or congenital anomalies. When managing these particular children with a TEF, the NPO status must be maintained, and suctioning of the upper pouch of the atretic esophagus must occur on a regular basis to avoid aspiration. As mentioned before, positive pressure can cause distension of the stomach, and this can impair ventilation and should be avoided if possible. Most common ways to induce these children prior to the operation, or if needed for airway management, it would be an inhalation or an intravenous induction by only giving gentle positive pressure ventilation. There is an alternative, which is rapid sequence induction. However, these are typically infants and they will rapidly desaturate. Unless you have an expert managing the airway and with the ability to rapidly intubate the trachea, rapid sequence induction is not always a desirable alternative. During the induction and intubation of these patients, it's often necessary to use a rigid or fiber optic bronchoscope to visualize the fistula itself. Placement of the endotracheal tube, at least the tip of it, should occur and be placed beyond the fistula itself so that during positive pressure ventilation, there's no insufflation of the esophagus or down the esophagus. If during the surgery, or after the intubation and positive pressure ventilation, it may be necessary that an emergent gastrostomy should be considered if ventilation worsens. Etiologies of difficult intubation in children are less likely related to obesity as it is in adults, but more so due to syndromes that can affect facial anatomy as well as skeletal development. Pierrot band sequence is one of the more common etiologies that leads to a difficult intubation in a child. PRS consists of retrognathia or micrognathia, cleft palate, and glossoptosis. This often leads to upper airway obstruction due to small anatomic space that's afforded by their small mandible and large tongue. Some of these infants actually are not able to lay prone and must be laid on their side. Some of these infants may not be able to lay supine, but must be laid in the prone position so that their tongue is able to not obstruct their airway. Tracheal intubations in these children can often be difficult to impossible, and it may be that a rigid bronchoscope is required for intubating these children. Fortunately, mask ventilation is usually easy to accomplish in these children. An LMA can be used, on the other hand, as a temporizing measure. However, if the airway obstruction in these children is severe, tracheostomy may be indicated, and this is typically then followed by more definitive mandibular advancement procedures. Treacher Collins is another unique pediatric airway concern. These children have mandibular and mid-face hypoplasia with variable eye and ear deformities. These children are notoriously difficult or impossible to intubate and may also be difficult to ventilate. The airway obstruction in these children is often related to the degree of their defect. In addition, they often have choanal atresia as well as glossoptosis. Additional difficult airways include Cruzan syndrome. These children, Cruzan is typically characterized by craniosynostosis, or premature fusion of the skull bones. These children have associated mid-face hypoplasia that could cause significant airway obstruction. Goldenhar syndrome is associated with eye columboma, vertebral or scapular anomalies. Other associated abnormalities include cardiac defects, renal and neurologic defects. Hurler syndrome is noted as a mucopolysaccharidosis, or as a lysosomal storage disease. These children often have coarse facial features and a large tongue and cervical spine instability, and they often have a very difficult airway, mainly related to their short and immobile neck, a high epiglottis, and a hypoplastic mandible. Once the child is intubated, a breathing circuit is used in the intubated child. The differences in breathing circuits is very important for neonates and infants, as increased resistance to flow is a major concern based on the decreased radius of the infant's trachea, as well as their need to have higher work of breathing. The circle systems nowadays have modern valves, and associated with a sophisticated ventilator, there has become less need for Mapleson-type circuits, but I will briefly review them here. The first type we'll talk about has no valve, and it's the Ayers T-piece. It's a simple circuit. Essentially, fresh oxygen flows in, and the patient breathes in and breathes out of a reservoir tube. The problem with these circuits is that it's wasteful of the gases, and there's also environmental pollution if anesthetic gas is included. In addition, there's no ability to ventilate this patient as there is no valve or balloon. Valve circuits developed out of the need to control ventilation. Closing an adjustable valve on these Mapleson circuits allows the addition of positive pressure ventilation as well as PEEP. Mapleson systems are classified based on the location of the fresh gas inflow and overflow valves relative to the patient connection. They all share the benefit of decreased resistance due to the absence of unidirectional valves and canisters, such as in our circle systems or current modern anesthesia machines. Unfortunately, rebreathing and the resulting hypercarbia and respiratory acidosis can become a problem. On the other hand, rebreathing does conserve humidity, heat, and anesthetic gases, which is a disadvantage of these Mapleson circuits. The degree of rebreathing in these circuits does depend on how high the fresh gas flow is. Mapleson A circuits, which is shown on the top, function best when used for spontaneous ventilation, as it results in no rebreathing during spontaneous ventilation if the fresh gas flow is greater than 75% of minute ventilation. During controlled ventilation, it does require very high fresh gas flows to eliminate rebreathing and is not ideal for controlled ventilation. On the other hand, Mapleson D systems require slightly higher flows during spontaneous ventilations than Mapleson A, but for controlled ventilation, they require very little flow and are preferred in those situations. Mapleson D, as can be seen on the slide there. The disadvantage of the Mapleson circuits, as mentioned before, is that they result in a loss of heat and humidity, and it can be wasteful of gases. The three-valve circuits, known as the semi-closed circle system, which is what the majority of pediatric and adult cases use today on a modern anesthesia machine, enclose, as mentioned, three valves. There's a one-way inspiratory valve, a one-way expiratory valve, and a pop-off. These also include CO2 absorbers that nowadays have less resistance to flow through them, making them more compatible for use in pediatrics. In addition, there's low compliance tubing and more sophisticated ventilators that offer pressure support ventilation. As mentioned previously, compared to the Mapleson circuits, the three-valve circuits are able to conserve humidity and provide some degree of thermal control. One of the major debates in pediatric anesthesia has been between whether to use a cuffed or uncuffed tube. The traditional thought was that the narrowest portion of the upper airway in young children was the cricoid ring. The feeling was that with a cuffed endotracheal tube, there would be undue pressure on the trachea, causing inflammation, injury, and post-intubation edema and croup. Another advantage of the cuffed tube is that pressure support ventilation can obviate the increased resistance of smaller inner diameter endotracheal tubes. And so you can decrease the size of the tube and avoid causing any tracheal irritation by providing some pressure support ventilation. Additionally, you have decreased OR contamination because you're using a circle system and the cuff blocks any flow coming around the endotracheal tube through the trachea. And you're able to increase your ventilation pressures as needed for children that have decreased lung compliance. Endotracheal tubes are typically sized by two different formulas. These are usually based on age. The common one used is age divided by 4 plus 4 can give you the outer diameter of an uncuffed tube. We typically decrease the outer diameter by 0.5 if you're using a cuffed tube. Another formula is the Coles formula, which allows you to calculate the diameter of the tube as 16 plus the age in years divided by 4. The length of insertion of an endotracheal tube can be done a number of ways, either in combination or individually. One would be direct visualization of placement of the endotracheal tube 2 to 3 centimeters below the vocal cords. You could also use the calculation that the distance from the lips is 3 times the internal diameter of the endotracheal tube. Auscultation of bilateral breath sounds can confirm appropriate placement. And finally, palpation of the endotracheal tube cuff in the suprasternal notch, and transmission of that palpation into the pilot balloon can indicate proper placement in the endotracheal tube. The OR can be a daunting experience for a child, particularly if there's no parent present during the induction or entering the operating room itself. Many anesthesiologists will give a pre-medication to help allay anxiety in the child, as well as for amnesia. Pre-medication can also allow for a smoother inhalational induction in younger children. There are many different medications with many different attributes. as well as different ways to administer them. The most common pre-medication is oral midazolam. However, many of these medications can be given via the intranasal route, intramuscular route, as well as transmucosal. And depending on the child, whether or not they will drink an oral medication will dictate how you administer a pre-medication or if one needs to be administered at all. If a child prefers an IV induction, or in the situation where there's a history or a suspicion for malignant hyperthermia, an IV will need to be placed in the child while they're awake. Topical anesthetics can be used in these situations, one of which would be EMLA cream, applied to anywhere where there might be an obvious blood vessel or in places where there's landmarks for blood vessels. In addition, you can use a freeze spray on the child to decrease the sensitivity while placing the IV itself. Distraction techniques are always very useful in a child. Parental presence during an invasive procedure is very controversial. Surveys indicate that the majority of parents prefer to be present for induction and would return to the OR for a second anesthetic. Parents also believe that they're a help to their child and the anesthesiologist during the induction. Parental presence is also associated with increased parental satisfaction. However, this slide illustrates the anxiety of a child during the perioperative period. On the y-axis is the Yale Perioperative Anxiety Scale. As can be seen, the anxiety of the pre-medicated group, which is the closed diamonds, is that there was decreased anxiety in the pre-medication group compared to the other two groups, both during induction 1 and induction 2 time points. This is compared to the control group as well as the parental presence group, which you can see that the anxiety was higher in the child. Oral midazolam itself, then, has been shown to be more effective in terms of reducing the child's anxiety and increasing compliance during the induction. Different techniques to induce a child have been used. As alluded to earlier, inhalational induction is the most common technique in pediatric anesthesia. Sevoflurane is most commonly used because it's non-pungent and exhibits minimal airway irritation. The typical inhalation induction is initiated in most compliant children with a 2-to-1 nitrous oxide to oxygen mixture. Once the child exhibits some degree of sedation, sevoflurane is introduced and increased to the maximum concentration of 8% as tolerated. Obviously, the hyperreflexic stage of anesthesia is prolonged in older children and teenagers. The rate of rise of an inhalational anesthetics into the lungs is determined by the delivered concentration of the anesthetics and the minute ventilation of the patient, and is quantitatively described as the inspired concentration ratio, FA over FI. Compared with adults, children demonstrate a higher minute ventilation per body weight and a higher tidal volume to FRC ratio, so the FA over FI ratio rises faster during inhalational induction in children. Certain aspects can change how an inhalational induction occurs. A higher cardiac output can actually slow the inhalational induction by decreasing the FA. A right to left shunt can also slow the rate of induction. It leads to basically dilution of the agent, whereas a left to right shunt can modestly increase the rate of induction by decreasing the AV difference of the agent in the lungs. As you can see from this slide, the effect of age on the minimal alveolar concentration shows that as infants up to 1 year of age, the MAC is increasing up until where it peaks at 1 year of age. And from then on, the minimum alveolar concentration then decreases with age as throughout teenage into adulthood and the elderly age groups. The other approach to induction would be an intravenous induction. Obviously, this would be preferred since it's faster in a child that already has an IV. You will avoid the unpleasant odor of inhalation induction. The disadvantage is that it requires placement of an IV and is usually reserved for children that are older, around the age of 8 to 10 years old, or even older if a child is not able to tolerate an IV. Once an IV is placed, multiple different agents can be used, Propofol is probably one of the most commonly used agents in pediatrics. During intravenous induction, certain shunts can cause a decrease or an increased rate of the intravenous induction. If there is a right to left shunt, this can increase the rate of an intravenous induction, whereas a left to right shunt can slightly prolong the effect of the intravenous induction. Physiologic changes in multiple organs and organ systems during development are responsible for age-related differences in drug disposition. The body composition affects distribution for the most part, and the most significant changes with age are in the total body water. The total body water is 75% body weight in a full-term newborn, and as a child ages and we become adults, the total body water decreases. By 5 months old, total body water decreases by 60%. On the other hand, body fat increases with age. Neonates and infants have the largest volume of distribution, and this is reflected then in a volume of distribution for water-soluble drugs. However, they also then have a smaller volume of distribution for the lipophilic drugs. The major practical effect, or the major practical value of the volume distribution lies in the calculation of initial drug dosing. The larger the volume of distribution, the larger the initial dose of drug required. Other components of pharmacokinetics include metabolism. The CYP-P450 enzymes in children reach near adult levels by 1 year old, with max at the puberty ages that they reach puberty. In terms of excretion, there's age-dependent renal clearance, and that's a major determinant based on age and drug dosing. Renal excretion is important for the water-soluble drugs and metabolites. In the next slide, I'll show you how the different organ systems develop over time. And by 6 months to a year old, the infant does have a mature renal system. And finally, clearance is the ability to eliminate a drug by metabolism or excretion by either the liver or the kidney route. Children have more blood traversing the liver and therefore often have a more rapid clearance in infants and children via the hepatic route. This slide illustrates the developmental changes in the physiologic factors that influence drug disposition. As reflected by panel A, the activity of many cytochrome P450 enzymes are markedly diminished during the first 2 months of life and then begin to increase to adult levels. Obviously, there's a different levels develop faster, different enzymes develop faster with age. Panel B shows age-dependent changes in body composition, which influence the apparent volume distribution of the drugs. Infants in the first 6 months of life have markedly expanded total body water and extracellular water, which is expressed as a percentage of total body weight as compared with older infants and adults. And finally, I'll discuss in this slide, is that panel D summarizes the effect of postnatal development of the kidneys, which, as mentioned earlier, approximates adult activity by 6 to 12 months of age. The different pharmacodynamics and kinetics of drugs affects dosing in children. The first specific drug I'll talk about is propofol. Infants have a larger volume of distribution, which requires then a larger induction dose for the infants and younger children. One characteristic of propofol that's important to note is propofol infusion syndrome. Propofol infusion syndrome is diagnosed by the constellation of bradycardia with either lipemic plasma, hepatomegaly, metabolic acidosis, rhabdomyolysis with myoglobinuria. The propofol infusion syndrome is associated with high-dose infusion, usually 400 micrograms per kilogram per minute infusion over a long period of time. Typically, it's been seen when infusions were over 48 hours. It's thought that the propofol infusion syndrome occurs by interference of propofol with mitochondrial function. Therefore, propofol infusions are typically avoided in the infants for more than 24 hours. This should not be confused with the fact that propofol is safe in the operating room for a reasonable amount of operating room times if needed. I'll next move on to opioids and the effect of infants and children development on opioid use. In laboratory animals, narcotics are more toxic to newborns than older animals. There's increased sensitivity to opioids and the respiratory depressant effects in neonatal animal models. Respiratory depression in infants may be a function not only of the lipophilicity of opioids, but also of the maturational changes in the opiate receptor pools. The low affinity receptors are present in larger numbers at birth, and those are associated with respiratory depression. Opioids have a large inter-individual variability in terms of the pharmacokinetics in infants and children. Therefore, dosing needs to be titrated. In addition, morphine clearance is 80% of adults at 6 months of age and then reaches near 96% by 1 year of age. Fentanyl clearance is markedly reduced in the premature infant, and use of fentanyl in those children needs to be closely titrated as well. The pharmacokinetics and pharmacodynamics of neuromuscular blocking agents are also different in pediatrics. Neonates and infants themselves are much more sensitive to these agents than children and adults, as can be seen in this slide. This is the different neuromuscular blocking agents. These are the ED95 by milligrams per kilo in the infant, child, and an adult. As you can see in the infant, the dose required is much lower in a child and typically lower than in an adult. However, the volume of distribution of the neuromuscular blocking agents is larger in children since all neuromuscular blocking agents are water-soluble. Therefore, a higher bolus dose would be required to achieve a given plasma level. But we use the same bolus dose in adults and children since infants and the young children, as mentioned before, are more sensitive to these agents. The final neuromuscular blocking agent to talk about is succinylcholine. This is a depolarizing neuromuscular blocking agent. It's the fastest acting with the shortest duration. There's some major pharmacological differences with it from adults. One important one is the vagal-mediated bradycardia. Typically, if succinylcholine is going to be used in a child, the administration of glycopyrrolate or atropine is given as a pre-medication. The potential for hyperkalemia exists in a child, and the black box warning that's associated with succinylcholine relates to any undiagnosed muscular dystrophies that could lead to a massive release of potassium upon succinylcholine dosing. In addition, succinylcholine is a malignant hyperthermia triggering agent, and this drug is avoided in pediatric anesthesia unless absolutely necessary. The non-depolarizing neuromuscular blocking agents include vecuronium and rocuronium, and they have a rapid onset time out of this class of neuromuscular blockers, but they do have a prolonged duration in infants and children compared to adults. Therefore, redosing needs to be adjusted based on train of 4 twitches. Cisatracurium has a more rapid clearance in infants. However, the dose and duration is the same across all age groups. Local anesthetics, typically in the bloodstream, are bound to alpha-1 acid glycoprotein. In children and some infants, these are not fully produced until sometime in the first year of life. Therefore, there's a larger free fraction of local anesthetic drugs in infants and children up to a year old, which could predispose to systemic toxicity if the appropriate dose is not given. Local anesthetic onset is more rapid, and there appears to be more local anesthetic spread in infants and children. Epidural fat is loose in the infants, and the thought is that the perineural sheaths are looser compared to in adults and allows more spread cephalad. This brings us to regional anesthesia. Typically in infants and children, as well as the pediatric population overall, the regional anesthetics are performed under a general anesthetic, as a child will not be appropriately sedatable for performance of a nerve block. The nerve blocks then typically require ultrasound guidance with or without a nerve stimulator. The occurrence of nerve damage is exceedingly rare, and regional anesthesia is safe in an anesthetized child. The most common local regional anesthetic performed in pediatrics is the caudal epidural. The caudal epidural is a single or even catheter placed into the caudal space, or a single shot of local anesthesia. The volume of the local anesthetic determines the height of the block. As shown in the slide, different doses are given based to to achieve a certain level of local anesthesia block. And the slide shows the anatomy, which is typically at the sacral hiatus where the needle is placed. Moving on to fluid therapy in infants and children. Infants have a higher metabolic rate and therefore increased surface area, which is inversely related to patient age. The water requirements therefore increase with decreasing age. The common 4-2-1 rule is based on maintenance caloric requirements, and this is how we typically calculate maintenance fluids in infants and children. As in adults, there are other types of losses during surgery, which include insensible, evaporative, third space loss, and also surgical blood loss. Solutions used or fluid therapy used typically are isotonic, non-glucose containing solutions for resuscitation and anesthesia, and those are used to replace the intraoperative fluid losses. Moving on now to fluid therapy, infants have a higher metabolic rate as well as increased surface area, and this is inversely related to the patient age. Therefore, water requirements increase with decreasing age. For maintenance fluids, the typical 4-2-1 rule allows us to calculate the basic maintenance fluid rates, and these are based on caloric requirements. As in adults, fluid loss is very similar, and they include insensible losses, evaporative losses, third space, as well as surgical blood loss. Fluids used in the intraoperative arena for fluid loss include the isotonic non-glucose containing solutions. In terms of glucose requirements, neonates, and in particularly premature infants, require dextrose-containing solutions during a prolonged fast, and this is due to their limited glycogen reserves. Glucose maintenance fluids are typically started on children that are less than 10 kilograms. Most common solution is a D5 half-normal saline that provided at half maintenance dose during the surgery. Children older than a year old rarely need any dextrose-containing solutions. In terms of blood replacement, there are few differences from the adult in terms of indication to administer blood products. And platelets should be administered in critically ill premature infants with a platelet count less than 50,000, and that's mostly for the concern of an intracranial hemorrhage. The typical, in terms of anemia itself in an infant, there's the physiologic anemia, and this occurs usually around 5 months of age. The typical hemoglobin at birth is around 19 grams per deciliter, and this is basically mostly composed of fetal hemoglobin, which is about 70% of that entire hemoglobin count. The fetal hemoglobin, oxyhemoglobin curve is shifted to the left, which means that oxygen is more tightly bound to the hemoglobin F, allowing it to take up oxygen from the placenta and then later distribute it to the tissues in the fetus, where the pH is a little bit lower, about 7.25 to 7.35. As the major driver of hemoglobin development, erythropoietin, it's not produced until hemoglobin drops to 9 or 10. The reason it drops to 9 over 10 is that hemoglobin SF, or the fetal hemoglobin, is replaced by adult hemoglobin. Once it reaches the 9 to 10 level, erythropoietin begins to be produced, and this represents the physiologic nadir, as I mentioned, around 4 to 5 months old in a full-term neonate, when physiologic anemia occurs, and the child starts to develop adult hemoglobin. I mentioned fetal hemoglobin just a slide ago. This is the curve which shows the oxyhemoglobin dissociation curve. You can see that hemoglobin F actually has a higher affinity for oxygen, which improves uptake at the placenta despite low PO2. You can see here that the fetal hemoglobin shown on the blue compared to adult hemoglobin shown in red, that for any given PO2, fetal hemoglobin has a higher oxygen saturation than the adult hemoglobin. The fetus has, as mentioned before, around 80% hemoglobin F, while the adult has around 90% hemoglobin A. The fetal hemoglobin the fetal pH is around 7.5 to 7.35, and this allows unloading of oxygen at the tissue level, even though fetal hemoglobin is the majority of the hemoglobin in an infant. Hypothermia in neonates and infants can increase oxygen consumption metabolic acidosis, as well as increase the pulmonary as well as peripheral vascular resistance while reducing cardiac output. Prematurity, hypoglycemia, and general anesthesia exaggerate a neonate's poor metabolic response to hypothermia. The neutral thermoenvironment is the environmental temperature at which oxygen consumption is minimal, and this typically occurs at a skin temperature of about 36 and an ambient temperature around 32 to 34 degrees Celsius. The compensatory mechanism for children then, when there is cold stress, is non-shivering thermogenesis. This is basically norepinephrine or thyroid stimulation response of triglyceride and fatty acid metabolism in the energy-rich brown fat. Brown fat is mostly deposited during the third trimester of pregnancy and is found between the scapulae and around major abdominal organs. Infants born before the third trimester have less ability to initiate the non-shivering thermogenesis and therefore are more prone to hypothermia. As I mentioned, as the ambient temperature decreases, this doubles, even to a temperature of just 2 degrees, is sufficient to double the oxygen consumption in a neonate and small infants. Therefore, the neonate must then double its minute ventilation to meet the increased oxygen consumption and may put a critically infant over the edge. So therefore, temperature regulation and maintenance in the infant and neonates, in particular the premature infants, is of utmost importance. Therefore, warming devices are commonly used. The most effective device for warming a child is a forced warm air device. These include the warming blankets placed over a child, and they work by conductive and convective warming. The disadvantage in these systems is that they can produce burns and overheating if used inappropriately. Another alternative would be a circulating water mattress, and these are useful. However, they're not as good as the forced warm air device mentioned above. Other devices used in addition to forced warm air devices are the overhead radiant heaters. These are very useful, although they can cause skin burns if they're too close to the child. They also result in insensible losses if used for a prolonged amount of time. Additional approaches to keeping a child warm would be wrapping the child or draping them with plastic sheets. And then it's important to always humidify the inspired gases, which is more common now that circular systems are used in pediatric anesthesia. Moving on to the neonatal respiratory physiology, the lungs are fully functional several hours after birth, and children basically develop the adult number of alveoli by about 4 years old. In small infants, the total lung capacity is around 60 cc's per kilo, and they reach near adult volumes of 90 cc's per kilo when they're 5 years old. A common misperception is that FRC in the infant is smaller than adults, and this is a misconception. The infants have a similar functional residual capacity. The difference is that infants have a very compliant chest wall and their ribs are parallel until 2 years old. And this creates a lack of the inherent negative pressure between the chest wall and the alveoli to generate FRC as in adults. So children require active recruitment of accessory muscles to maintain the negative intrathoracic pressure. And they also use a phenomenon called laryngeal braking to generate PEEP. And this essentially is when they use their adductor muscles of the larynx to act as an expiratory valve during mid-exhalation or end exhalation to maintain PEEP, and that by restricting exhalation. Unfortunately, when we administer a general anesthetic, most of these mechanisms are abolished, and under a general anesthetic, infants do exhibit a decreased FRC. The diaphragmatic muscles in infants and children contain less slow twitch, high oxidative, and more fatigue-resistant fibers. The child has a similar tidal volume to adult, but infants have a higher oxygen consumption. Increased minute ventilation to the FRC ratio results in a rapid desaturation when apnea occurs in an infant or child compared to an adult. Ventilatory control in a child exhibits a normal response to hypercarbia. However, in response to hypoxia, the initial response of a neonate is to increase ventilation and then followed by prolonged decreased ventilation. And this is not what's typically seen in an adult, where you would see a maintained increased ventilation due to hypoxia. Other maladaptive responses that neonates have that results in respiratory depression or apnea can occur when there's lung inflation, stimulation of the carina, or upper airway obstruction. Neonates don't behave in the typical fashion that would be expected as in an adult. Right? All right. Other components of neonatal respiratory physiology include surfactant. Surfactants are phospholipids and proteins that are produced by type 2 pneumocytes, and they reduce surface tension of the alveoli, which prevents collapse of the smaller distal airways during exhalation. The surfactants production is actually decreased in premature infants and other conditions associated with prematurity. Other conditions that reduce surfactant include persistent pulmonary hypertension with severe pulmonary hyperperfusion and hypoxia, a severe congenital diaphragmatic hernia or with immature lungs can be damaged by the ventilator. Meconium aspiration syndrome can also decrease surfactant production, as well as ARDS. Another concern in neonates is oxygen toxicity. By providing too much oxygen, there's a bronchopulmonary dysplasia can occur, and that's associated with oxygen exposure. We'll talk about bronchopulmonary dysplasia in a few slides. However, other complications of oxygen toxicity include retinopathy of prematurity. There are also other major organ systems that can be affected by oxygen toxicity that are, at this point, undefined or unknown exactly how it occurs. Use of supplemental oxygen then should be limited in neonates, basically to just maintain a saturation between 85 and 93%. Apnea of prematurity is a concern for the pediatric anesthesiologist, and this consists of cessation of breathing for greater than 20 seconds or less if it's accompanied by bradycardia or hypoxemia. It is common in premature infants, and it can be seen in about 90% of infants if they're less than 1.5 kilograms. What's observed is typically a mixed central as well as an obstructive apnea, and this is caused by neuronal immaturity of the respiratory control center and peripheral chemoreceptors. Most of the time, this can be treated with tactile stimulation, airway maneuvers, and if needed, IV caffeine in these patients. Postoperative apnea is a major concern for the anesthesiologist. It's strongly and inversely correlated to both gestational age as well as the post-conceptual age. Studies have shown that postoperative apnea in infants greater than 44 weeks old post-conceptually is decreased significantly to only 5%. Other than age of conception, other significant risk factors for postoperative apnea include anemia with a hemoglobin less than 10, hypoxia, and hypothermia. The postoperative apnea is a major consideration for whether a child should be admitted after a general anesthetic, depending on their conceptual age. Bronchopulmonary dysplasia is a chronic disease of the lung parenchyma and small airways with chronic respiratory insufficiency. This typically develops after acute ventilator-induced lung injury and oxygen toxicity in the premature infant with severe respiratory distress syndrome. It is defined as oxygen dependence for at least 28 postnatal days. Most of these children depend on oxygen, and they usually require some degree of PEEP. They always have persistent lower airway obstruction and airway hyperreactivity later in life. This is very important for children requiring additional procedures, especially associated with prematurity, which include inguinal hernia repairs, as well as other surgical repairs in childhood. Moving on now to the neonatal cardiovascular physiology, fetal transition starts with the first breath. Air is drawn into the lungs, and fluid is then absorbed. Lung fluid is then absorbed and expelled. The fluid-filled alveoli expand with intrathoracic distending pressures. During this time, PVR immediately decreases secondary to establishment of the negative intrathoracic pressure during inspiration, and also due to the increase in PaO2, decreased PaCO2, and correction of fetal acidosis. You can see that within the first 24 hours, the ABG normalizes. During this time, the SVR will rise due to the clamping of the umbilical cord. The combined increase in SVR and decrease in PVR will no longer allow blood to flow through the ductus arteriosus. At the same time, the sinus venosus will atrophy. Left atrial pressure then increases, and this causes the flap valve of the foramen ovale to close, and this will thus establish for the first time the circulation in series. The ductus arteriosus will close over the first several hours as a result of the constriction of the specialized contractile tissue within its arterial wall, which is mostly due to the loss of the placenta-derived prostaglandin, as well as due to increase in oxygen tension and a decrease in blood acidosis. The fetal circulation can persist, though, and conditions that cause this include hypoxemia, hypercarbia, and or acidosis, which prevents the normal decrease in the pulmonary vascular resistance and closure of the ductus arteriosus. Causes of this are respiratory distress syndrome, meconium aspiration, hypothermia, and congenital heart disease. Congenital heart disease can be simplified to an extent by thinking in terms of blood flowing to areas of least resistance. So blood flow can either be blocked by obstructions, or it can be or rerouted by the persistence of fetal circulations or other types of shunts. Obstructions can be right-sided, meaning obstruction on the right side of the heart, and this usually results in some sort of right to left shunt where blood will bypass the lungs. This often leads to hypoxemia or cyanosis. An example of this would be tetralogy of Fallot, where there's decreased flow through the pulmonary valve and blood then shunts from the right to the left through a ventricular septal defect. If there's obstruction on the left side, this can often result into a left to right shunt. These can lead to either tissue hypoperfusion as well as acidosis and shock. Shunts can occur at the level of the atrium or within the ventricle or at the level of the PDA, most commonly during congenital heart disease. If it's a right to left shunt, the pulmonary blood flow is decreased, and again, this results in hypoxemia and cyanosis. If there's a left to right shunt, on the other hand, what you find is there's volume and pressure overload on either or both of the ventricles. Ultimately, this over time can lead to congestive heart failure. Finally, if there's pulmonary overcirculation and the blood cycles into the lungs, back into the heart and shunts from the left to right through a VSD, then what occurs is pulmonary overcirculation. And this over time, if uncorrected, can lead to pulmonary hypertension. This is a listing of the cyanotic heart defects. Hypoplastic left heart syndrome, tricuspid atresia, all of which result in either in hypoplastic left heart syndrome, a hypoplastic left heart, or tricuspid atresia, which results in a hypoplastic right side of the heart. Tetralogy of Fallot, when there's decreased outflow through the pulmonary valve, shunting occurs from right to left through a VSD. When there's pulmonary atresia with an intact ventricular septum, again, there's no form of pulmonary blood flow other than through a persistent ductus arteriosus. Similarly, pulmonary stenosis will limit the amount of pulmonary blood flow. And then finally, transposition of the great arteries is when there is complete Transposition of the great arteries occurs when there is discordance of the great arteries in the ventricles themselves, leading to a cyanotic defect. The acyanotic defects include simple ASDs, VSDs, or the atrioventricular septal defects, or endocardial cushion defects, a persistent ductus arteriosus, or PDA, coarctation of the aorta, or aortic stenosis. As mentioned before, pulmonary hypertension is a major problem. Typically can occur in neonate and can persist over time. Pulmonary hypertension can occur by a number of different processes. What it is essentially is structural changes in the pulmonary vascular bed that typically occurs from increased pulmonary blood flow. Pulmonary hypertension is defined by a mean pulmonary artery pressure by greater than 25 millimeters of mercury. What it leads to is a medial hypertrophy and necrotizing arteritis in the pulmonary circulatory system. Pulmonary hypertension can either be reactive, meaning reactive to sildenafil or nitric oxide, inhaled nitric oxide. Fixed, which means unable to ameliorate the problem, or it could be a combination of reactive or fixed. Factors that increase PVR include hypoxemia, hypercarbia, acidemia, hypothermia, as well as sympathetic stimulation in extremes of lung volume. In children or adults that have pulmonary hypertension, any of the above factors that increase PVR should be avoided. Coarctation of the aorta is a common problem. It occurs by a ridge-like thickening that originates from the aortic media, and it protrudes into the lateral and posterior walls of the aorta. The aortic lumen is further compromised as the child grows, and distal perfusion, perfusion of the extremities beyond the coarctation itself will be limited, leading to decreased growth, as well as possibility of acidemia if it's severe. This is often not an isolated lesion or a localized disease process, and is oftentimes associated with bicuspid aortic valve or other congenital heart defects. The major pathophysiologic effect is an increased afterload on the systemic ventricle. This increased afterload results in left ventricular hypertrophy and the hypertension, which is proximal to the lesion, and then hypotension distal to the coarctation. In the fetus, blood flows, as we saw before in fetal circulation, from right to left to supply the body with oxygenated blood that returns from the placenta, and this occurs through the ductus arteriosus. After the child's born, the PVR falls and blood begins to flow from left to right through a persistent ductus arteriosus. Normally, the ductus arteriosus will close within the first few hours to days of life. However, a PDA can persist due to low oxygen or a high PCO2, acidosis, or persistent pulmonary hypertension of the newborn. Large PDAs can steal considerable blood flows from the systemic circulation, which lowers the diastolic pressure and can put the coronary circulation as well as the perfusion of the gut at risk. So neonates can be at risk of NEC. Pulmonary overcirculation can also occur and ultimately can lead to CHF. If the ductus arteriosus does not close within a reasonable amount of time, and there is respiratory distress or an increased pulmonary vascular resistance, increased respiratory distress, the ductus arteriosus needs to be surgically closed if it's not able to be closed by indomethacin. A vascular ring is an aortic arch anomaly, and typically the trachea and the esophagus are compressed by the surrounding vascular structures. This typically presents with signs of stridor and dysphagia, as well as wheezing, dyspnea, cough, and recurrent respiratory tract infections. The vast majority of how this occurs is that there's a double aortic arch with right arch dominance, and the right arch has mirror imaging branching, and this arch, as well as an aberrant left subclavian artery, can enclose the trachea and esophageal structures and ultimately compress them. Some anesthetic considerations then with congenital heart disease depends on the type of surgery that is being considered. For instance, corrective surgery, the considerations are that with the child coming to you, if they're not an extremis, cardiac output needs to be maintained. In an infant, one of the most important components of cardiac output is the heart rate, and therefore the heart rate needs to be maintained or increased. In addition, preload needs to be appropriate, and contractility may need to be augmented with different medications, or at least maintained. Normoxia is also important. Some of these children will have mixing lesions or shunting lesions, and their saturation will be normally, or at least in the child based on the lesion, 75 to 85%. For that child, that's an appropriate saturation. On the other hand, if the child is saturating at 100% and should have a circulation in series, then they should be maintained at their normal saturation, which is 100% oxygen. In order to maintain a normal pulmonary vascular resistance, normocarbia should also be maintained. And also, if you're trying to avoid overcirculation of the lungs, slight hypercarbia can increase PVR, depending on the lesion. If the child is coming to you and the circulation is well balanced, then you want to avoid changes to the pulmonary vascular resistance to systemic vascular resistance ratio, as you don't want to change the pulmonary blood flow ratio to the systemic ratio. in order to avoid pulmonary overcirculation. Or on the other hand, if the QP to QS is decreased, that could result in hypoxia as well as acidosis. Other anesthetic considerations are in a child that requires palliative surgery. The most common palliative techniques are the Blalock-Taussig shunt, and this is for a child with pulmonary atresia or decreased pulmonary blood flow through a typical right outflow tract. These children need augmented pulmonary blood flow through a shunt that occurs from either the subclavian artery into a pulmonary artery via a Gore-Tex tube as shown in the picture on the left. On the other hand, children that exhibit too much pulmonary blood flow may have the requirement for a pulmonary artery band, which creates a restriction of pulmonary blood flow by a mechanical band placed around the main pulmonary artery or branch pulmonary arteries. The hybrid procedure is a palliative approach in a child that either is extremely premature and requires some degree of growth before attempting a repair of a congenital heart lesion. The hybrid procedure includes stenting of the ductus arteriosus as well as banding of the pulmonary arteries to limit pulmonary blood flow. The stented ductus arteriosus in this particular picture here is a means to provide systemic blood flow beyond this small aortic arch, and then the pulmonary artery bands are placed to limit pulmonary blood flow and overcirculation. Children with congenital heart disease that present for non-cardiac surgery is a unique group that are at extreme risks of adverse events. These children can be at any stage of palliation. They could either be unpalliated, partially palliated, or completely palliated. Obviously, the stage of palliation should be noted prior to any surgical procedure, and detailed knowledge of the anatomic as well as physiologic function of the child's heart is essential. It is recommended that cardiology clearance is obtained for these children and they've had a recent echocardiogram. In the unpalliated child, and the child presenting for non-cardiac surgery, typically they're going to be either hemodynamically stable and awaiting definitive repair. And this could be the child that has a tetralogy of Fallot that requires another surgery more urgently. Children with partial palliation may include a child with a hypoplastic left heart syndrome or, on the other hand, tricuspid atresia, both of which only have one systemic ventricle, and they're awaiting subsequent staged repairs. And finally, there could be children presenting that are totally corrected. And they have unique anesthetic considerations depending on the type of repair that they had. Either it be that they have a Fontan circulation, or they had an atrial switch operation for transposition of the great arteries. So the vascular ring is an aortic arch abnormality. Most commonly, it's a double aortic arch with right arch dominance. This occurs basically with the trachea and the esophagus that become compressed by surrounding vascular structures. The presenting signs and symptoms include stridor and dysphagia, wheezing, dyspnea and cough, and recurrent respiratory tract infections that are unable to be treated or diagnosed by conventional methods. The typical repair of this is either repair of the aorta or aortopexy to separate compression of the trachea and esophagus. Anesthetic considerations for children with congenital heart disease depend on what the actual surgery is proposed, as well as what stage of repair these children are presenting. In children that require corrective surgery, it's important to maintain their cardiac output. The child with congenital heart disease, if not in extremis, will require maintenance of their normal heart rate or even potentially increased heart rate, as that's the most important component of cardiac output in a neonate or infant. Preload is also important to maintain. Prolonged NPO status should be avoided, and an IV should be placed ahead of, preoperatively, and the child should be given appropriate fluids. And finally, contractility may need to be augmented by epinephrine or milrinone. Normoxia should be maintained. If the child is an acyanotic heart disease, then their saturation should be 100%, and they should be maintained at 100%. However, some lesions have mixing of saturated and unsaturated blood in have mixing of blood, usually in the atria, of saturated and desaturated blood. And these children typically have a saturation of around 75 to 80% on their pulse ox. And these children should be maintained at that level. And in addition, normocarbia should be maintained, and in children that are exhibiting some degree of pulmonary overcirculation, it might be prudent to allow slight hypercarbia to increase PVR and decrease the pulmonary blood flow. If the child is in a balanced state, meaning that they have a balanced pulmonary blood flow to systemic blood flow, then changes to the PVR, or the pulmonary vascular resistance, to the systemic vascular resistance ratio should be avoided, as an increase in the pulmonary blood flow in relation to the systemic blood flow, that could result in pulmonary overcirculation, whereas a decrease in pulmonary blood flow could result in hypoxia and acidosis. The types of palliative surgery that typically occur in children with congenital heart disease are mainly a Blalock-Taussig shunt or pulmonary artery banding. A Blalock-Taussig shunt, as shown in the picture on the left, is essentially a Gore-Tex tube which allows additional pulmonary blood flow to be shunted into the pulmonary artery from either centrally or, as shown in the picture, from the subclavian artery. This allows for increased pulmonary blood flow in children with restricted pulmonary blood flow. The children, on the other hand, that have unrestricted pulmonary blood flow, either due to shunting or a large PDA, may require a band placed on their main pulmonary artery, on the branch pulmonary artery, to mechanically restrict pulmonary blood flow. And that's to avoid pulmonary overcirculation in certain children. And that's shown here on the right, in the right side of the figure. The hybrid procedure, on the other hand, is typically used in a child that's either born prematurely and that requires growth before attempting repair of their congenital heart disease, or it's used in children with multiple comorbidities that may not necessarily tolerate a complete repair of their lesion. The hybrid procedure essentially consists of placement of a stent in the ductus arteriosus, and that's typically done by an interventional cardiologist, and then by sternotomy, surgeons will place bands on the pulmonary arteries to restrict pulmonary blood flow. The stented ductus arteriosus then serves as a method to provide systemic blood flow. Children with congenital heart disease that present for non-cardiac surgery are at increased risk of adverse events. These children can either be unpalliated, partially palliated, or completely palliated. The stage of palliation should be noted, and a detailed knowledge of the anatomic and physiologic function of the child's heart is essential. It is important to obtain cardiology clearance for these procedures. The child that is unpalliated may be hemodynamically stable and awaiting definitive repair. An example of this would be someone with tetralogy of Fallot that requires repair of their incarcerated hernia or other more urgent disorder. Children that are partially palliated might be a child with hypoplastic left heart syndrome who is awaiting repair of the subsequent stage repairs. And finally, children could be completely corrected, and unique considerations are required for the type of repair that was done. For instance, the child could have Fontan circulation or have had a arterial switch procedure for transposition of the great arteries. Each of the approach to each of those diseases needs to be individualized for the condition and the residual anatomy that the child has. Commonly in later life with chronic congenital heart disease, the baseline oxygen saturation of the patient should be determined. In most children that have circulation in series should have 100% saturation unless there's some degree of a residual shunt. In children with congenital heart disease that are older should have a low threshold to cancel the case with a URI if it's elective. Oftentimes the increase in pulmonary vascular resistance, and in particular in someone with a Fontan circulation, is quite undesirable, as their pulmonary blood flow contributes significantly to cardiac output. Medications need to be reviewed, including any drugs for afterload reduction, diuretics, antiarrhythmics, antiplatelets, and anticoagulants. One of the most common problems with children with congenital heart disease later in life is arrhythmias. And cyanotic congenital heart disease can oftentimes be compensated with polycythemia. So a complete blood cell count is important to perform on many of these children, as well as taking note of any electrolyte abnormalities. Children with chronic congenital heart disease should also avoid a prolonged NPO status. This is particularly important for children with a Fontan circulation, hemi-Fontan or tetralogy of Fallot. These children require higher preload, and during induction or high-dose induction agents, decrease in their systemic vascular resistance may decrease their cardiac output by decreasing preload to the right side of the heart. As mentioned earlier, an increase in the pulmonary vascular resistance is a major concern. Right ventricular hypertrophy and possible right ventricular failure can occur if there's a significant increase in PVR. This can be avoided many times by just optimizing ventilatory management, maintaining normocarbia, as well as avoiding hypothermia. As I mentioned, arrhythmias are very common in these children. They should be maintained on their antiarrhythmics if they're on them, and close attention should be paid to the EKG. These children also may have some degree of congestive heart failure, either due to a failing ventricle or due to volume overload. And finally, many of these kids will have residual valvular stenosis and or regurgitation, and an analysis of the echocardiogram should be performed preoperatively. And that concludes this section of the pediatric anesthesia.